Hello, and welcome to the Ask Nurse Linda webinar. I wanted to take a moment, first of all, to thank all the people that work. These webinars always look so effortless, but there's a lot of people behind the scenes. So Julie and Jen are with us today, working behind the scenes. We have a captioner, we have a sign language interpreter, but there are a lot of people in the Christopher and Dana Reeve Paralysis Foundation that are working diligently on behalf of people with any kind of paralysis from any source. And I just wanted to take time and highlight those people. There are people that information specialists that you can contact if you have any questions about things. I'm on the web. There's a place where you could hit if you want to ask a question directly to me. There are all kinds of people who are doing webinars. There are, on the other side of the foundation, there are people that are doing scientific research and bringing that to you. And there's so much that's going on in research right now. This is really a boon time. So it's an exciting time to be looking at some of these things. So thank you to all those people that are working so diligently. And of course, then also the people in the community, people with paralysis and their family members. How many people are contributing every day to their knowledge and understanding, and the peer mentoring program where they're helping other people kind of deal with those rough times. So, it's a group effort and we're all working together. So thank you to everyone for that. Now, the last few webinars, I've started out with heat and protecting you from the heat. Unfortunately, the heat has gotten even worse. And the heat is one thing, so you need to try to keep yourself cool. If you don't have an air conditioner in your home, it's time to consider one. There are organizations in most cities that will provide a window unit, and then you can also get reductions in your electrical bill if you can show financial need that you need that service. So look for those organizations that can provide at least a window unit if you don't have air conditioning in your house. That will give you at least one cool room where you can cool down, go someplace to cool down. You can still go out for a while, but then you've got a place where you can go and be cool. They're cooling centers if you don't have one of those. I mentioned the heat, but also what's even worse is the humidity. You know what they always say, it's not the heat, it's the humidity, but that's so true, because heat will dissipate from your body. When you get into a cooler temperature, your body will cool down with a cooler temperature. Humidity collects in your body. And that's why air conditioning is so important, because it conditions the air to take out some of that humidity. And that humidity collection takes hours and hours and hours to dissipate. But you have to be out of the humidity to let that happen. So, usually at night things will cool off and people then tend to cool off. But if you have temperature regulation, that is probably not going to happen. So if you can get air conditioning, if you have that, if you have it, if you can ask for financial assistance with your electrical bill. If you qualify for that, there's in the chat box, there's place cooling centers by state. So that will give you a place to go. Now, I have seen some of these little tiny room air conditioners that you put water in. It's like a little tiny box and you plug it into the wall. I bought one. It cooled the room a little bit for a while. Different brands probably work differently, but I just thought, well, I'm just gonna see how this works. And it worked. It only worked for a period of time because it's a small device and you have to keep refilling it. You also have to clean it because remember, water collects bacteria. So like a dehumidifier or vaporizer in a child's room, you have to clean those. You also have to clean those. But anyway, it helped for a little while. And so I thought, well, this is kind of a cool thing. If you are going someplace where there's not going to be air conditioning, you can plug that little thing and then just have it blow on yourself. It's kind of a cool thing. I can't recommend it. I'm just saying it's just something different that's out there. So we have lots and lots of questions today. So let's just hit right into it. Our first question is from somebody who is C4 quadriplegic in 1980. They're beginning to have more nerve pain in my buttocks and hips. Is this normal? Well, I can't say that it's not abnormal. Some people have this and some people don't. It's how the nerves are responding to the paralysis. And it's that lack of communication between the nerves in the body and that communication to and from the brain. So some people do get spasms, or they get nerve pain. And what it is actually this is kind of ironic, but it's actually those nerves are regenerating, and they're trying to find an alternative pathway to get messages to and from the brain. And that's what really is causing that. So it's really a good thing, but it's really annoying too. It can be painful. Nerve pain is very, very difficult pain. Those that are listening that have had nerve pain or no nerve pain, it's like lightning bolts going through. This is tingling, this burning, this itching. It comes in different forms and facets. So there are treatments for nerve pain. There are medications that are designed specific for nerve pain. That's gabapentin and pregabalin, the Lyrica and the Neurontin. Those are the only two that are specifically designed for nerve pain. Now, those are pretty significant medications. Some people start those medications, no problem, they're on it. Some people have difficulty starting, and it takes about 8 or 9 days to kind of get accustomed to those medications. So if you can tough it through the side effects for that, then usually people are okay. The body gets used to them. They have to be upped over time as the pain continues. The other medications that are given are anti-epileptics, which are seizure medications, and antidepressants, medications for depression, that are given in very, very small amounts. So the amount that's given wouldn't treat depression, it wouldn't treat your seizures. But in little small amounts, they will help with some of this nerve pain. It's a side effect of the drug. So you take little tiny amounts of these for that. Now, if you need to go off any of these medications, you have to titrate off. Your body becomes used to taking them. And so you can't just stop them. So you have to titrate off them very slowly. And I talk about this a lot, but I have people that would come into the office all the time, and you tell them you've got to titrate. Oh yes, I'm going to titrate off this. Here's your plan for how to get off this. Oh yes, I'm going to do it. And I say, now don't go cold turkey. Whatever you do, don't go cold turkey. And I'll explain, you have to titrate off these drugs. They'll come back a few weeks later. Linda, I should have listened to you. I went cold turkey, and now the pain is more severe. If you don't titrate off these drugs, if you don't wean off of them and go off of them slowly, the pain comes on like a roaring freight train. To get back on the medications, it takes a lot more medication. It's a lot more difficult to treat. So don't ignore that. Don't go off slowly. I need to mention that with that. But there are medications. Now, some people will do other kinds of treatments. They'll have they'll do some acupuncture, they'll do some biofeedback, they'll use distraction. So there's all kinds of things that people do. The medication's one thing. If you're having spasming with the nerve pain, there's Botox that can be given for that, Botox injections. So some people do get this later on. It's a good thing, but it's also sometimes just intolerable. So, getting treatment for it, that's an important thing to do so that you're not uncomfortable and you can continue on with your activities. Sometimes when people, sometimes they'll want to change medications. They'll say, okay, I've been on this seizure medication or this antidepressant medication in low level, and I think now it's time that I go on the Neurontin or the Lyrica. And so you have to get completely off the one drug before you can start another drug, or they'll want to change from the Neurontin to the Lyrica or the Lyrica to the Neurontin. So they titrate off, and that can be a difficult time period because nothing's controlling that neuropathic pain. But for some people, it's just an odd thing that happens. They titrate off, and once they're off their medication, they say, my neuropathic pain is gone. This is a few people. And there's no predicting so far that we know of that, like in a year or 10 years or whatever, that this pain will be gone. We don't have any idea, but sometimes it does go away. It just wears itself out and it goes away. So, if that can happen. So I put that out there just for people's edification, because, it's always nice to know that pain can go away. The next question is, after 5 years, I'm getting crystals and sediment in my urine. It's blocking my suprapubic catheter. Now I have to change it weekly. How do I eliminate the crystal settlement? Is there a risk to changing that catheter that frequently? Well, people change their catheters at different time frames. Some people do change it weekly, especially when they're having this clogging issue. If you have a suprapubic catheter, it most generally is because you have a tendency towards autonomic dysreflexia. So that catheter getting clogged can lead to autonomic dysreflexia episodes. So it's important that that does not happen. So you want to be sure and try to eliminate that sediment that's collecting in that catheter. You need to talk to your urologist about what the cause of that is. There's a variety of causes. And so you need to really talk to your urologist to find out what's going on with that. See if there's some medication, see if you can increase your fluids. If you're taking in a lot of sugar with your fluids when you're drinking, that can lead to urinary tract infections, but also it can kind of increase that sediment, because maybe your body is trying to get rid of some of that bacteria. Bacteria loves to grow in sugar. It's the favorite thing they love to grow in. So if you're drinking a lot of sugary sodas, sports drinks has a lot of sugar in it, alcohol has a tremendous amount of sugar, it's all coming out through your urine. So that can be one of the reasons for the crystals. So there's just a variety of reasons. So be sure and check with your urologist or your healthcare professional to find out why that is, so you can work towards reducing that. Sometimes they'll recommend irrigation to clear out some of those crystals. That is very individual. So I'm not saying go out and start irrigating. Sometimes people will say, no, absolutely don't irrigate, but we're getting into a lot more on things about irrigation as well. Here's a question that somebody wrote in about, this is from Paul. My wife had crooked arteries, so catheter would not reach a clot in her left brain with damaging results. This needs research solution. And I know Paul has been doing a lot of research on his own. And again, this is so important for people in the community. I think Paul has a medical background. And so this is important to look at all this information and see what's going on. And there actually is a lot of things that's going on. I know that we had talked about stem cells, and those, were being significantly reviewed as early as the 1990s. And remember, that was the big thing. It was on the news, and this was the thing that was going to happen. And there's been a tremendous amount of progress in stem cell repair issues. So there's still a lot more work to do, but there has been leaps and bounds made in that research. There's all kinds of research that's going on. So this is the time really to be interested in this sort of thing, because there are treatments that are being done. A lot's being done with electrical stimulation that's providing function, which is a supplement, but looking for a cure to paralysis is quite a big undertaking. So know that that is ongoing and that things are moving very rapidly. Although when you're the person that's waiting, it's never going rapidly enough. I realize that, especially from personal experience in my own family. It's not happening fast enough. I need it now. But things are happening and things are really moving along. So we have to keep on top of that and follow that pretty carefully. Okay, is there an advantage to an alternating wheelchair cushion to repeated pressure sores? Do participants have recommendations? This person started on a J2 deep contour gel and now is using a J cushion foam with a small Rojo insert. So is there an advantage to alternating pressure cushions? Well, alternating pressure cushions usually set up in chambers so that when one chamber is filled, another chamber is emptied or lowered in pressure, and then it automatically rotates around. They're usually in patterns of 4 distributions on the cushion. And so that pressure changes in the different cells as it goes along. Also, the Rojo cushions that have the little finger projections that you sit on, and your bony prominences kind of fit in between. So if you look at those fingers, your bony prominences kind of sit in between those and take the pressure off where that bone is pressing on the inside of the skin. So people use all kinds of different pressure dispersing equipment. And I say dispersing because you need to disperse the pressure. You need to spread the pressure out under those bony prominences. And you can use them on your bed, you can use them on your chair. The important thing to remember is that there is no piece of equipment, absolutely none, that will completely eliminate pressure. They can reduce it an awful lot, and they're very, very good pieces of equipment. But there's no piece of equipment that's totally going to take that away, unfortunately. So you have to do pressure releases even with your equipment. So you have to push up, do your push-ups with your wheelchair if you're able to do that. Some people will bend from side to side, and it's not just, it's not like I'm doing just for a quick second. It's like counting for 10 seconds, work up to 20 seconds, get 30 seconds off that skin. So you have to really work at this. You have to do it very frequently. The more frequently you do it, the better. What are some of the other things about pressure? So which pressure cushion is the best? Well, it varies by people. So some people who are heavier will have more body weight being put on that skin, but people who are also lighter have more difficulty with pressure injury because there's no muscle there to help disperse. Muscle actually helps disperse pressure over those bony prominences. So if you can get equipment, electrical stimulation that helps build up your muscles. Now, some people won't respond to electrical stimulation, but they will respond to manual movement. So doing your exercises, doing your range of motion, relieving pressure. If you're in a power chair, you can use that tilt button and change your position, which will help change your pressure on your rear when you're sitting. The other thing I wanted to mention too is something I was thinking, but I lost that thought. Be sure and use equipment that disperses. So use medical grade equipment. Some people will say, oh, pillow's cushiony, or I got some foam at the craft store, because really that's all these things are, just foam cushions. No, the medical grade ones are made with a different kind of foam. The cells are made in that foam. They have cells in the foam. They're made up of little tiny bits of things. And so those are made up differently than the foam you get at the craft store or with a pillow. That increases pressure. So definitely don't use that kind of thing. Get medical grade. Now you can go to your physical therapist and you can do pressure mapping, which is kind of an interesting thing because if you go to the Walmart or you go to a store where they sell Dr. Scholl's, they have this pressure measure thing that you can stand on, and it shows where the pressure is in your feet so that you can see what kind of shoe insert you need to buy. It's a good sales technique, but it also shows pressure in the feet. Well, now imagine that if you're doing that for the whole body. So you can go to your therapist and get a pressure mapping system that will show where the pressure is on the body, where you're sitting, when you're laying, when you're on your side, however you position your body. So that's kind of a neat thing because it will tell you and help direct what kind of equipment that you need. But still, you have to do those pressure releasing. I think everybody everybody that I know and have interacted with has always relied too heavily on the pressure dispersing equipment. It is important. It takes the edge off, but it's not going to completely avoid those pressure sores, that pressure injury. So you really need to do those push-ups. If you do get a pressure injury, the best way to get rid of the pressure injury is to stay off of it. Now, this really bothers a lot of people because they're like, no, I need to get up. I need to go to the store. I need to go to work. I'm going to school. I need to sit up and be with my family. But the quickest way to get rid of a pressure injury is to stay off of it. Sometimes people will stay off of it. They stay off, at night. They don't turn on where the pressure injury is. They will do the pressure. They'll stay in bed during the day, staying off that area, but they'll get up to brush their teeth. Well, remember, when you get up and the minute you put pressure back on that pressure injury, you've just negated your whole 24 hours that you were off of it. So these are the kinds of things. A pressure injury you want to avoid, because it's easier to avoid it than it is to get a pressure injury and try to heal it. Any grants or exercise equipment for quad conditioned persons? Well, there are some organizations that will give grants to different people. Locally, it's probably better now to look locally around your community, because people in different organizations will help sometimes buy equipment. You need to find a person in an organization that's interested in your cause. So if you say, I call up, the Lions Club, or I called up this organization, and they say, oh no, we don't do that kind of thing. You need to work around in those organizations and find somebody who might be interested in your cause that can champion that for you. So it's a difficult challenge. And I know everybody wants the latest and greatest equipment. Insurance does not always cover that. It becomes very frustrating because we know from research that equipment is beneficial, but because of the size of the research populations and because of the cost of the equipment, it gets very hard to justify. Keep going back to your payer. Keep going back. They will, first of all, if you ask for this equipment in the first round, you will be rejected. And some people, oh, I was rejected, and so that's the end of it. No, there's an appeal process. Keep appealing it. Some people take like years, but they will eventually get the equipment. Here's a place up there for grants and financial assistance in the chat box, which will give you some ideas of some different organizations and how to do that. There are organizations, Help Hope Live is one, for example, that will help you fundraise and get equipment. They do have a financial burden that goes with that, but they are really good at getting that. So, it's helpful in looking at some of these different organizations. Here's a person that's multi-disabled, and I think we've had this question before, where this person's nearly blind, has the macular degeneration, is paralyzed from the waist down, and they need more hope. And hope is, this is an elderly person who's 96. Never let age be the point where you say, well, there's no hope for this person. There's always hope. It's finding those rays of sunlight. The research that's going on, different treatments that are going on can be helpful. So this lady has macular degeneration, so there are it's vitamin treatment that's given to everybody. The AREDS 2 is the preferred vitamin. There's AREDS 1 and there's AREDS 2, but AREDS 2 is the more preferred one. So that can help stabilize the eyes. And then doing the paralysis, keeping the exercise going, keeping the movement going, and working with the person. So talking to the Alzheimer's Association can provide some different helpful techniques also as well. So just keep going with what's, as long as you're breathing, you've got an opportunity. So keep going with what's going on in research and how things are progressing. The next question is from a person that was told that their daughter, who's 21 years old, bladder is very small and her urethra is thinning. The doctor recommended catheterizing every hour, but we know that's impossible. I'm very confused on what's best for her. So that is kind of an unusual thing to catheterize every hour. You might want, but for some reason your doctor recommended that. So you probably need to talk with him and get his thinking behind that and what's going on with that. Now, yes, catheterizing every hour would be a bit of a challenge. It might be time to think about an indwelling catheter or a suprapubic catheter or other kinds of means, a ileostomy, a urostomy. Talk with this healthcare professional about other options, because sometimes things are recommended, but in reality, like you say, we all know catheterizing every hour is going to be kind of a bit of a challenge, unless you have a caretaker that's there. And it's really kind of a quality of life issue as well, because for your daughter to be catheterized every hour, and for a female to be catheterized, that can be a bit challenging. So however you're doing it, if it's on the toilet, it's a little bit easier. I'm just assuming you're probably doing it where you have to get them back in bed and disrobe, and there's a whole lot of bits and pieces that go to that. So talk to the doctor. We have information about bladder care and all the different ways that you can treat bladders, and that is on the Reeve website. So you can look up bladder, and there's a whole lot of information there about different options, different things that you can do. So if you haven't been to the urologist, maybe it's time to go there. So they might be able to do something about the urethral thinning. They might be able to do some injections there that might help. And so there's just a whole variety of things, but go back to your healthcare professional, ask them what the thinking is, ask them what the alternatives are. We can't say, or I can't say, this is what your daughter needs, because I don't know your daughter, but be sure and look up that bladder care sheet on the Reeve Foundation. I think we'll see it coming up here pretty soon. And that will give you ideas about different options that you can say, what about this? What about this? And maybe that physician will come back and say, well, that's really not a possibility because of this reason. Or, well, gee, I hadn't really thought about that. Or do you want to go to something that is that invasive, such as an indwelling catheter? And here's the reasons why I think you should or you shouldn't. So your physician wants to work with you. Your healthcare provider, if it's a physician, if it's a nurse practitioner, they really want to work with you and do what the thing is that you want to do. So be sure and look up those kind of things so that you can have that conversation with the healthcare provider. Here's a person that's recently disabled from spinal cord injury on 3/16 in 2019. They have increased spasm in spite of taking medication. I'm looking for, can you take both of these together? But I don't see what the other medication was. They're taking methocarbamol, but they don't say what the other medication. More options than just a baclofen pump, natural supplements. Well, if you're having increased spasms, what most people are doing these days, yes, there's a lot of medications that you can take orally. People sometimes don't like to take them because as they relax the muscles, they also relax your total body. Some people get from the oral medications, they kind of get a brain fog and they don't like that, or they feel real lethargic because it's relaxing all the muscles in your body. And so people sometimes don't like the oral medication, but the thing that most people are doing now are taking Botox in the muscles that are doing the spasming. And that seems to provide a lot of relief to a lot of people. That, I would say, is probably the most common thing that people are doing now. The thing after that would be the baclofen pump, but you're not interested in that. So again, we talked earlier with the first question about spasms and nerve pain. So there's a lot of information in there that you can do with the spasms, but some people will do range of motion exercises that will release the spasms, because if you can relax the muscle doing those exercises, then the muscle will be too tired to spasm. They have to be done frequently, and then people get weary of, I'm always moving my leg, or I'm always doing this for these spasms. And so sometimes people will opt for other treatments. The nice thing about the baclofen is it works locally. So if you have it injected into your leg, it's only going to affect that muscle in that leg. It's not going to flow throughout your whole body in particular. So that's an important thing to do. But moving your legs will help fatigue that. Sometimes people can't move enough to fatigue the muscle, but if you can do any kind of electrical stimulation, sometimes that will fatigue that muscle. So there's a variety of things that you can do that are not oral medication wise. Here's the next one, is a person who has a spinal cord injury, C2-6, 73 years old, injury 4 years ago. Well, keep going, keep doing the exercising, protect your skin. As we get older, our muscles get a little thinner, our skin gets a little thinner. Things happen just with the aging process. So it's going to be very important to protect your skin and keep moving your body. That's going to be the most healthy things to be doing. This person is wondering about lower motor neuron injury and bowel and bladder, specifically incomplete injuries. Can spinal cord injury patients learn to strengthen sphincters? Well, that is a very good question, because in those lower motor neuromotor injuries, those muscles usually are flaccid. Now, it's an incomplete injury, so some muscles will be working and some muscles won't be working. When toileting in the lower motor neuron, people may do a self-catheterization. They may toilet spontaneously. They may do some nerve reflex things to help themselves toilet. So some people will toilet and they will do tapping across the area of the bladder on the outside of the skin, and that will trigger a reflex reaction and cause them to void. Some people will push themselves up, and that will cause more pressure in the lower abdomen, which will cause a spontaneous voiding. Some people will stretch the rectal opening, and that causes a reflex arc. So some people who do bladder or bowel programs will notice that they toilet when they are inserting the suppository or doing their stim. They'll notice urine coming out of the bladder. So sometimes there's a reflex arc that you can capture doing that stretching of the rectal sphincter, the external rectal sphincter, and that will cause bladder to come out. So those are some of the things that you can do. If you can strengthen your muscles, so you have an incomplete injury and those muscles are weak in the abdomen and in the bowel and the bladder area, sometimes you can strengthen those by contracting and relaxing those. Excuse me. If you have some muscle preservation there. So sometimes that can work. I don't know in your particular case if that can work or not. There are some devices that can be inserted into the rectum that causes an electrical stimulation that will help stimulate the rectal sphincters. Sometimes that can help the bladder as well. That's something that is an option that may help electrical stimulation. With the new devices that they have, for some people who have lower motor neuron injury, incomplete injury, sometimes those will stimulate the bowel and bladder muscles. So that might be an option for you. I don't know if that is for you in particular. It's something you can ask your healthcare professional about. You could be possibly tested with one of those devices to see if it would help you. So that would be an option. I'm trying to think. Those are about the things that I can think of. Moving your legs also moves the muscles in your abdomen. So it's kind of a trigger effect. So that would be an option as well. So those are some of the things that you might be able to do. So you should remain optimistic. With an incomplete injury, you should remain optimistic. If you are able to walk, that is certainly going to help strengthen your abdomen. Even if you walk with braces or reciprocal gait orthotics, if you're able to get up and walk, that's good. If you can't walk, that's okay. Just move those legs, move up in those hip joints and get those muscles going. So you have a lot of reason to be optimistic about that. Autonomic dysreflexia. How can I help my caregiver and medical team understand how to tell when I need help? This is really critical. This is very important. So one of the things that you might want to do is to print off from the Reeve Foundation website, and I'm sure we'll see it coming up in the chat box, a link to the autonomic dysreflexia trifold. It's a little tiny piece of paper that you can print it off for free. So you can print as many as you want. You can hand out as many as you want. It's folded up. It comes out to be about the size of a dollar bill if you decide to fold it. And you can put it in your wallet. You can print these out and hand them to your medical professionals. It has all the signs and symptoms of AD. It has what to do if somebody has AD, and it has the medical references to why you need to do this. As soon as you meet someone who's taking care of you, it should be the first thing that comes out of your mouth. I have this thing called autonomic dysreflexia. Most people will have never heard of it. Medical healthcare professionals, if they're not dealing in the world of spinal cord injury or head injury, because people with head injury, about 60% of the people with head injury, stroke, have it as well. So what you will find is that most people have not heard about it. They maybe learned about it in school. If they don't deal with this population, it's something I heard maybe 20 years ago when I was in school. It's kind of hard to recall. So print off this wallet card because it is so critical. There are other wallet cards as well for sepsis, and they come in all kinds of language. There's several of them, so keep all of them on hand, but just print them off and say, you need to know about this for me. It's a matter of life and death, and this card will tell them how serious this is. This should be the priority when you meet somebody. If you go to the emergency room and say, I suffer from AD or autonomic dysreflexia, hand them one of these trifolds. Always keep them with you so you can just hand them out freely because it has all the information. So this will give people the information that they need. So if you start having the symptoms that are listed there, if you're having the pounding headache, if you're having blurred vision, goosebumps, if your pulse is changing, if you're feeling just kind of nervous anxiety, this impending doom, there's all kinds of symptoms, and AD can be triggered from almost anything. The big three, of course, is a clogged bladder, something stopping urine from coming out. That's number one. Number two is an impacted bowel or even diarrhea. Number three is an issue with the skin. So something is kinked or rubbing up against your skin. You're maybe developing a pressure injury. You have a pressure injury. I've known people that have AD from using their computer, and the light from the computer triggers AD events. Some people have extremely severe AD and they're not able to tell somebody what's going on. And so you need to have this information so that your caregiver can look at you. What they need to do is take your blood pressure to see if there's a change in your blood pressure, and the parameter of change is on that for pediatrics and for adults. There's a pediatric card and an adult card. The parameters are on that. If they had that, they need to take emergency measures and get help right away. They need to check your bladder, number one. They need to check if that's flowing freely. They need to check the bowel. They need to look at your skin. If you're wearing pants that are too tight, the skinny jeans, Nurse Linda does not like the skinny jeans, causes too much AD, causes pressure injury if they have little rivets in them. So the fact that skinny jeans are going out, it makes me completely happy. The other thing is that, you know, some people have AD so severely, just even a cool breeze or a warm breeze, any kind of, you're sitting in your house and you're by a vent and a breeze blows by you, that can tickle those little hair fibers on your arms. So there's all kinds of causes that can happen to that, but that is the first thing to tell somebody. You might want to get a medical alert bracelet or necklace that says that you have that, because if you go to the doctor or you go to the hospital emergently and they see that medical alert, they're going to look at that tag and see what's going on with you. So that would be an important thing. But if you know, hand these out, just, you go to the emergency room for something else, you go to your doctor, oh, I wanted to give you this pamphlet, this little trifold about AD. I want to have this on my chart so that everybody is aware that this is a situation that concerns me. And then if you have caretakers, be sure that this is posted on your wall. Be sure they have their own copy. Bring it up frequently to be sure and watch for that, because being prepared is the way to treat that issue. You may need medication to control the AD. That's another thing that is a situation. So if you do need medication for controlling of that AD, be sure that they know where that is. Sometimes people who take nitroglycerin for heart issues will have take the little pill bottle and pin it to their shirt, because if it's that severe, you want it ready for somebody to be able to give it to you. You can do the same thing with your AD medicine, you know, so that if you have that frequently and you need medication, you don't want to have to rummage through your bag or, you know, a drawer, or what did I do with that? Keep it by your bedside. Keep it where you are. So if it's by your bedside, but you've gone out for the day, it's not going to do you any good. So keep it handy and keep it where everybody knows where it is. Okay, the next one. I'm a C3-7 incomplete with a left above the knee amputation. I suffer with horrible, painful spasticity in my residual limb. None of my doctors has any idea how to deal with this. So this is a problem with amputation, phantom pain. And it usually picks up in the residual limb. So the part of the limb that's left on the body is what the residual limb is. So spasticity is treated as spasticity. It's too much tone in a particular muscle, and it's usually a nerve going to that. Botox is really a treatment for spasticity. Again, there are those medications to deal with that, but you will want to think about what you want to do. But Botox is usually the answer. The interesting thing with amputation is this phantom limb process, where sometimes people will feel like they're having an itch on their toe, but their toe's no longer there. And so that can be, that's why they call it phantom, because the nerves that would connect to that toe or the foot or whatever part of your leg that has been amputated, the nerves up above that are still searching for that lower part of your leg. They don't know that that is now gone. So they're still looking for that. And so sometimes people have pain or it's spasticity, these kinds of things that are very irritating. So ask about Botox injections. Again, I can only tell you things that you might want to consider, but that seems to be the current best treatment for spasticity. I don't see any reason why it wouldn't work for you. It's, as I mentioned earlier, it's injected into the muscle. It helps relax that muscle. It does need to be repeated after 3 to 6 months, depending on your particular case. So you have to go back for injections, but they're not huge. They're injections into the muscle. So you would have sensation there, as opposed to somebody who's paralyzed who maybe doesn't have sensation. You would not need that much Botox, because you're just really looking probably at 1 or 2 muscles or 1 or 2 places in one muscle. So it's something to think about. If you have a problem with getting those injections, or you find that they're really kind of painful, you can ask for lidocaine cream to be applied to the top of the skin. It's a topical application, and that provides anesthesia just to the top of the skin, and so you don't really feel the needle as much. So that can be an issue if you have a concern about pain with that. If you have a needle phobia, then that's another thing altogether. That's just something that you have to work through, maybe with a psychologist or therapist, to get over that kind of phobia. But you can get lidocaine, because that might be more painful to you having sensation. So those are a couple of things to think about. Here's a person that's an incomplete C5-6 with sensation. They intermittently cath, but have never had a bowel program or followed a bowel program since onset was 1980. I need to go every day, but it gets right to my anus and will not come out. My husband's been using digital stim. Well, that again is not unusual. That external sphincter sometimes clamps down and gets some spasticity into it. Most of the problem with removing stool from the bowel comes from the internal sphincter, because that is the one that is controlled by the brain. We have no control in thinking about the internal sphincter. So sometimes there's some changes in people's bodies over time, and this might be the issue that's coming. There might be some spasticity in that internal sphincter, and maybe that's what the problem is, because when you're doing the digital stim, that's inserting the finger high up into the bowel. The internal sphincter is about 3 inches up in the bowel, but it's a little different for everybody, but it's just about the length of your finger. So if you have somebody who has really small hands, you might think, oh, that sphincter's not that high up. In children, sometimes people will look at that. Sometimes you use the pinky finger. Sometimes you don't have to go in that deeply, because if you look at the size of an infant's finger, it's only about that long. So you don't have to go in that far, but it usually correlates to the finger. So that is an issue. But if you're doing the digital stim, that's also not surprising. With an incomplete injury, things changed. I would be kind of surprised if you were doing intermittent cath and not having a bowel program all this time, but I guess good for you. Usually people have to do intermittent cath also have a neurogenic bowel. So because the nerves come out at the same level of the spinal cord, so they divide off and are separate, but they come out at the same exit point. And so usually it goes hand in hand. But anyway, so good for you. But so, if you have to do the digital stim, but that you have to go, that those are all good things. Now, with an incomplete C5-6, you could do the digital stim yourself if you don't want your husband to do it. So that gives you a little more freedom and independence. But that is entirely your call. There are digital stim devices. If you're finding that the digital stim is in some way not desirable, you can get digital stim devices that you can insert and do the digital stim. When you're doing the digital stim, you want to be sure you're relaxing that internal sphincter. That's usually where the problem is. The external sphincter is usually under control of our brains. That's how we keep from having bowel movements in the middle of a meeting or, at a social affair. We're able to control that external sphincter. That's the one that's controlled by the brain, open, close. Time to relax. I'm in the appropriate place where I can have a bowel movement. So that's how that works. So it's usually that internal sphincter that's leading to the problem. So anyway, those are some options about thinking about those. Here's a question from someone who is C5, 6, 7 quad, 7+ years, having more frequent bouts with low blood pressure, 2 recent hospital stays for passing out and wondering why. They put me on a low dose of midorine. Sorry, I'm not saying it correctly. Is this common? Well, again, it's not uncommon. It's not that common, but it's not uncommon. So as we age, and sometimes with spinal cord injury, blood pressure keeps going down. Now, ironically, over time, most people's blood pressures will go back up to normal. This is new information that we found out in research. So it's kind of odd to be going the other way. It probably has something to do with the vessels in the legs. If you're not doing much movement with your legs, the blood vessels in the legs pump the blood from the legs back up to the body. So if those blood vessels you have become older, and sometimes the blood vessels don't pump as well as they used to. And so that can be a problem. You might need to go back to wearing the elastic hose. Some people will go back to the elastic hose and wear an abdominal binder as well. You can improve that blood flow from your leg by several times a day doing range of motion to those lower extremities. If you have access to electrical stimulation, that's been demonstrated to help with that blood flow. Something that you would want to do is to be sure and use some elastic hose, do some exercise, because you would be at higher risk for blood clot. If that circulation is actually the problem, that probably is. It's just as we age, that's the way that kind of thing goes. Here's a question about bowel movement, bowel management. I'm using a water enema of about 1,000 milligrams every other day to produce a bowel movement. Before I got my shower chair, I was lying on the bed on my back using a diaper for a bowel movement. Explain. Well, if you have a neurogenic bowel, the peristalsis is very slow. And again, that's the stool moving through the bowel. So after paralysis, the bowel moves more slowly. The whole time stool is moving through the bowel, water's being excreted. And so it becomes drier and drier, and the stool becomes harder and harder, and it makes it more difficult to propel through the already slow bowel. The other thing is that pushing it out can become difficult, as we were talking about in the couple of questions up above. So we don't usually recommend water enemas and huge volumes like that flushes out the bowel, but it also stretches out the bowel and can cause the bowel to become lazier because there's little fibers that help move the stool along, and that bowel squeezing along, this just stretches if you think of the bowel like a balloon, that all that fluid is going to stretch out the bowel. And the more that bowel is stretched that significantly, the less it contracts back down. So over time, that's going to cause more problems. And you're eventually going to end up with a colostomy or some other kind of problem because of this huge amount of fluid. So most people will use a suppository, either Ducalox or the Magic Bullet suppository, which stimulates that peristalsis in your bowels to work a little bit harder to get that stool out. Then they also use the digital stimulation and the bowel program link. Did we put the bowel program? I know we put the bladder program link. I'm not sure if the bowel program link went up there. So there is also more information about how to do the bowel program. Now, the advantage is you got your shower chair, and so that lets you have gravity to help drop the stool out of your body. So they were lying on their bed on their back using a diaper for the bowel movement. When there gets so much stool in your bowel, in a neurogenic bowel, sometimes it's going to overflow, and the pressure of that stool in the bowel is going to overflow the pressure of that internal sphincter, and the stool's going to come out, but not all the stool will drop out, and your bowel will not be cleaned. So it's better to have that stimulation using a suppository. There is a thing called Enemies, which is a mini enema. It's only a tablespoon of fluid, but it stimulates the nerves of the bowel to work. So that's another option. So you have those three options of using that and then using the digital stimulation, and that will completely evacuate your bowel. If you have not been doing anything for your bowel program, and it was just coming out, it probably was not complete, and you probably maybe overstretched your bowel. So you need to talk to your healthcare professional about what would be the best way for you to transition to using some other kind of bowel program to help keep that bowel healthy. So that would be an option. But getting that shower chair was a very good move, because that, if you do your bowel program on the shower chair, you're sitting up. Gravity is our best friend in bowel programs. So a lot of people overlook that. Most people are taught in the rehabilitation hospital how to do their bowel program in bed, because they're still having spinal shock. You have a limited time. Your bowel's not going to be regulated usually until after you're discharged. And so it becomes kind of a catch-22 for people to do these kind of changes at home. But there is a bowel program sheet, bowel information on the Reeve Foundation, that will help you learn how to do a bowel program that will completely evacuate the bowel, so you won't have those incontinencies, and you'll be providing good health to your bowel. So for the long run, it will be much more healthy for you to do a regular bowel program. Paul wrote in. He's our friend with the wife who's had the stroke. And so he says, I got my friend with a stroke something electrically stimulate paralyzed side to maintain muscle tone. Forgot what it was. I bought it and the friend didn't write the email back reminding me what it is. There are nerve stimulators that are available on the internet, but you do want to talk to your healthcare provider, because they are lower level stimulators, so they don't provide a lot of input. So you want to talk to your healthcare provider and make sure that the person is ready for electrical stim, because they could have a contracted muscle, or they could have a hidden blood clot. If they haven't exercised that arm for a while, there could be complications. So always check with your healthcare provider to make sure that it's okay, and to make sure that you're getting a stimulator that will actually do something to those muscles that are helpful. So there are stimulators that some people use to help correct foot drop, and they're lower level stim instead of these larger stimulator things. So talk to your healthcare professional to make sure you have the right one. You can get very cheap ones on the internet, but sometimes they aren't the right thing, that aren't doing anything for you. He's registered his wife in Neuralink with Elon Musk. That's FDA for clinical trials. She's waiting. I got to give credit to this Elon Musk. He comes up with the best ideas, and he's in so many things. He fascinates me as an individual. Now, there are a lot of other companies besides Neuralink that are doing a lot of different kinds of things for nerve stimulation. So look around, make sure you cover the full plethora of what's going on in that nerve stimulation thing. Neuralink is very experimental at this time. I'm not saying anything derogatory about it. I love all these options that are available to people, but we need to see, what's going on with them and how these things are going to carry out. Elon Musk wants to connect to the iPhone Vision Pro. It's obvious. It's easy. It has leads connecting to the nerves and run to the nerves and enable paralyzed motion. Now, what Elon's doing is with the Neuralink, he wants to do implants into the brain. There's a lot of success going on with external plants. I shouldn't even call them plants, with external stimulators that are getting a lot of rave reviews. So in looking at the spinal cord segment, the history of development was that we started out with external electrodes on different muscles in the legs and on the in the muscles on the rear end, and that created this movement in the legs for biking. Everybody knows about the FES biking. That evolved into developing implants that would go right onto the spine. And those are still being worked on. They've been through clinical trials. What they found, though, is that if they put the stimulus right over the outside of the spine where it's needed on the skin that they're getting excellent results with that. And they're still working with the implants, but they're working with that external treatment as well. So that might be an option in the future. There are several companies that are working on those that include Onward, Spinex, and Anuvo are 3 companies. Now, those are for spinal cord injured people, but it might be before you jump into something as big as an implant, which is up to you, because there are implants in the brain for Parkinson's disease and all kinds of things that are quite successful. So there's no reason why we shouldn't think this wouldn't be successful as well. But just look at the whole plethora of things that are out there before. You might want to try something non-invasive before you go in the invasive route. So all these things, we just have to wait and see how these are going to turn out. But it's an exciting time with all of this stuff that's going on. Paul also says those phantom pain nerves are afferent, but the afferent ones can be connected to bionic prosthesis. He has links to the CBS News clips on this. Yes, that is so true. There are things that can be put on the body that can interrupt those kind of phantom pain kind of things that go with the amputations. So that is another option. This lady was talking about spasticity, and I don't see why one of these bionic kind of things would help. That's going to be a huge cost to somebody. As far as like insurance payment or the payer paying for those bionic things, they might want to try a trial of Botox, again, starting with the easiest thing before moving on to a more complicated thing. Although the Botox is an injection, where the bionic is more surface stimulation. So, these are all things that have to be weighed. So it's best to talk to your healthcare professional. There are all these things on the horizon. These bionic prosthesis devices are so fabulous. If you see any of these, if you look them up on the internet and you see the different companies that are doing this, they allow movement for people who wear prosthesis, but it's wired into the nerves of the arm, not physically wired, but I don't know, should I say it's like some kind of transmission that wires into the nerves of the residual limb, that then your brain is controlling the prosthesis. So it makes it much easier to do instead of trying to manipulate a regular prosthesis. It's a little more complicated. So there's just so many things going on with all of this. And at that, we are at the top of the hour. So my recommendation is to get all the information you can. That's what we try to present on the webinars. We have some professional webinars. If you go back and look at the Christopher Reeve YouTube channel, you will see that there are professional webinars that we talk to different people that are talking about the latest and greatest things. So look for those. They've all been recorded. There are new ones that will be coming up. And so these are a lot of things that are going on. Paul has another thing that he says there's a matrix grown by stem cells at SCI where nerve pathways regrow. Yes, that is true. That was one of the biggest things that was the biggest hurdles to get over, was once you got the stem cells into the spine, how to get them to grow. And they have created that matrix, but there's still problems and issues and concerns with getting the stem cells in there and making sure that they multiply correctly. But yes, they do have the matrix now for how to grow them within the spinal cord. So you see, there's a lot of progress that's being done all over and all kinds of things. What helps one group of people helps another group of people. So the research in spine helps people with brain injury. The research with brain injury helps people with Parkinson's. The research in Parkinson's helps people with ALS. The research in ALS helps people with MS. All this stuff all fits together because how the nerves work are how the nerves work. And what we find out in one discipline helps all of us. So keep on top of it, keep following along. This is all, it's all coming together slowly but surely. It's all coming together. So I thank you for listening today, and please come back again next month.